Okay, perfect. Awesome. Okay. So, uh, can I continue?
Yeah, sure.
Okay, I'm going to go back a little bit. So prevalence. Did you hear this part, or can I start from prevalence?
Yeah, start from here.
Okay, so it's important to know who in the population is affected by low back pain. So we're going to talk about prevalence. So the prevalence of low back pain varies based on gender, male or female, age, education, and occupation. Typically, women have a higher prevalence of low back pain. And as we get older, there's also a higher prevalence of low back pain. And as we also get older, the more severe forms of back pain continue, and they actually increase in prevalence with age. That makes sense, right? Because of genetic predisposition, because of changes in anatomy, changes in bone density, specifically decreases in bone density as we age, particularly in postmenopausal women. You know, also due to lifestyle and previous medical history, sporting history, work history, our ligaments may begin to fail or not work as effectively. Our muscles may not work as effectively. As we age, our metabolic rate slows down. There may be weight gain. This in turn affects the integrity of the muscle corset around the low back. So there's many reasons why more severe forms of low back pain tend to increase as we age. It makes sense logically, right? Interestingly enough, lower educational status is associated with increased prevalence of low back pain, with longer episodes of low back pain duration, and with worse outcomes. Now, there could be many reasons why this is, but you know, if you have a lower educational status, maybe you have a menial job and you don't have the resources to seek medical or rehabilitation help. Maybe you don't understand the reason why active therapy is more effective compared to passive therapies for low back pain. So there could be many reasons why lower educational status is associated with increased prevalence of low back pain. But I think it's important for us as students who are training to be physiotherapists, and for those of us who are qualified physiotherapists, to understand prevalence and how it's affected across our patient population. Because the way that I would talk to somebody who is university educated may be a little bit different from a housewife, perhaps, okay? I will use different language and different strategies to convince a medical student or a physician why an active approach to treating low back pain is more effective than a passive approach, compared to how I would convince a housewife that an active approach is more effective than a passive approach. So understanding your audience and your patient population and the prevalence of low back pain within the various patient population subgroups is important. Okay, what about prevalence among the working class? So we know from research that people who do more physically demanding jobs, what we call material workers, there's a greater prevalence. It's actually double. The prevalence of low back pain is double in material workers compared to sedentary workers, okay? So why this is important to know is your approach to somebody who does a lot of heavy lifting as part of their job. For example, in Pakistan, a bricklayer, somebody who lays concrete bricks to build houses. The way that you would treat their low back pain is different from the way that you would treat an office worker's low back pain, okay? The physical conditioning that you would need to guide your patient through should be far more aggressive for the bricklayer than for the office worker. They should both get an active approach, But you're going to have to do much more strengthening, I believe, for the bricklayer because they have a heavier job. They have to be able to go back to that job without re-experiencing an exacerbation of their low back pain. So again, knowing our patient population is important. Okay, so why do we care about low back pain? We know that it's the most prevalent condition, musculoskeletal condition. For those of you who read research, who do research, you will be familiar with the Lancet. It's a reputable scientific journal. In 2018, they put together the Lancet Low Back Pain Series working group. And this working group consisted of experts on low back pain. And what they found was that there was worldwide mismanagement of low back pain. So not only is low back pain being mismanaged here in Pakistan, it's being mismanaged all over the world. And I'm going to share with you how that is, okay? There is unnecessary care being provided in both high and low income settings in North America, in Europe, in India, in Pakistan, everywhere. All over the world, we are doing a very poor job of treating low back pain. Why? Because we're not following the guidelines. There are expert guidelines backed up by research that are freely available to you and me, to everybody on the internet. They don't cost a penny. You can access them for free. We don't read them and we don't follow them, okay? The unnecessary care consists of complex pain medication like opioids. It consists of spinal imaging tests like MRIs, EMGs, CT scans. It consists of interventional therapy like spinal injections. It consists of needless surgeries, okay? And all of these things in a low and middle income country like Pakistan cost our patients a lot of rupees, okay? Going to the emergency department because you have sciatica, the typical Pakistani cannot afford that. It's very expensive, right? Unless the treatment is free. But then we have to wonder, what is the quality of treatment? They get pills, they get an injection. That only treats the symptoms. Does it address the cause of the problem? No. Okay? We're not addressing the cause of the problem. We are simply masking the pain. So globally, not just in Pakistan, all over the world, there's mismanagement of low back pain because we are not following established, evidence-based, research-based international guidelines, okay? And I'm going to share with you what those guidelines are in a moment. So if you, again, read research, which we should all be reading, okay, at least 5 to 10 articles a week. If you want to be a good physiotherapist, you must read research articles. I can't emphasize that enough, okay? You don't have to be an expert, but you need to read research to know what techniques work and which techniques don't work. It will completely revolutionize your practice. It'll make you a better physiotherapist. Okay, I'm sorry, I get sidetracked. The care track studies.
No problem.
The care track
No
studies told us that 28% of healthcare for low back pain in Australia and 32% of healthcare for low back pain in the USA was inconsistent, did not follow established evidence-based clinical guidelines. In a 2018 meta-analysis, it was shown that simple imaging tests were requested in 1/4 of back pain consultations, and complex imaging, like MRI, overall had increased by over 21 years. Why is this a problem? I'm going to tell you why this is a problem, okay? Instead of doing a proper assessment, what orthopedic surgeons, what physiotherapists, what neurologists do is they look at the MRI and they see that at L4, L5, there's a disc bulge. That must be the reason why the patient has pain. Wrong. Completely wrong. If you take 10 people in our presentation today, of those 10 people, nobody will have back pain. But if you do an MRI on every single one of those 10 people, over 70% of them will have some sort of finding on MRI, but they're completely pain-free. What does that mean? That means that there's no correlation between clinical presentation and what you find on an MRI. You cannot base your assessment, your diagnosis, and your treatment on an MRI. You have to base it on your clinical assessment of your patient. Okay? You can take 10 people who have low back pain. Okay? You do an MRI on them. 50% of them minimum will have clear MRI. Where's their pain coming from? There's no disc bulge. There's no facet arthropathy. There's no degenerative disc disease. There's no spinal stenosis. Where's the dard? What's causing the pain? We have to stop relying on diagnostic testing. We have to go back to the basics of physiotherapy practice, which is clinical assessment. Dermatomes, myotomes, reflexes, range of motion, exclude red flags, okay? We cannot rely on MRI. More and more clinicians, whether it's physios, whether it's neurologists, physiatrists, orthopedic surgeons, it doesn't matter. They are relying more and more on MRI and X-rays. 1/4 of people with low back pain get imaging, and the occurrence of MRIs has increased over the last 21 years. There's no need for that. Okay? We're wasting our patients' money. Okay? Now, spinal fusion. Spinal fusion surgery is a complete waste of time and money. There is absolutely no robust evidence that shows any benefit for spinal fusion surgery. I will guarantee you that if you have a patient with low back pain, they come see you, they say, Dr. Saiba, my neurosurgeon has said I have a L4, L5 disc bulge, both dard hai. They will do a discectomy. Okay, they remove the disc between L4, L5, and they fuse the vertebrae. That's spinal fusion surgery. There is no evidence for that. For people who have low back pain due to spinal degeneration, if they do spinal fusion surgery, there's no improvement in their back pain. Zero. Okay? You can see from 2004 to 2015 in the USA, for people who underwent elective spinal fusion surgery, even though there's no benefit for spinal fusion surgery, there was an increase in this type of surgery by 62%. Okay? We are doing the wrong treatment for our patients. As physiotherapists, if we do a better job, they don't need surgery. It's our job to convince them that they don't need surgery. Most low back pain is self-limiting. Even without physio treatment, without medical treatment, in 2 years, it gets better on its own. It's not serious. We're making it serious. It's not serious. Okay? We need to understand that. Okay, so what did the Lancet working group do? They told the WHO that we have to pay more attention to the burden of low back pain and the need to avoid unnecessary and excessive medical intervention. Okay, this was a very important recommendation. Why? Why was this an important recommendation? Because this gives allied health professionals like physiotherapists a chance to make an impact on how to effectively treat low back pain. We, physiotherapists, you, my colleagues, physiotherapy students in training, DPTs from all over the world. We are qualified to most effectively treat low back pain if we follow the evidence. IFC doesn't work, my friends. TENS does not work, my friends. Manual therapy, very limited application. Acupuncture, taping, doesn't work. Look at the research I'm going to show you. I will convince you. We have an important role to play if we follow the evidence on what is effective for the management of low back pain. Okay? Okay. All 6 of the major international guidelines that have been released and published and that are freely available on the internet, okay, since 2016. It's only been 5 years. All of the major international guidelines that have been released in the last 5 years prioritize non-medical approaches for the treatment of patients with low back pain. That means they don't need injections. They don't need surgery. They don't need opioids. They need evidence-based, active, good quality counseling, education, and physiotherapy, an exercise-based approach. That's what they need. Okay, this is all in the guidelines. I'm not telling you this. International experts are telling you this. Okay? Now, what about diagnosis? When a patient comes to you with low back pain, we, as physiotherapists, are obsessed with diagnosis. It doesn't matter. It does not matter if it's a disc bulge. It does not matter if it's spinal stenosis. The label does not matter. What matters is identifying impairments, excluding red flags, acknowledging the signs and the symptoms, treating the impairments. If you treat the impairment, you will affect disability, you will affect function, you will improve the patient's quality of life, and you will improve their pain, guaranteed. The label or diagnosis you put on doesn't matter. We get distracted. That's not important, okay? What's important is excluding red flags. If there are no red flags, it doesn't matter what the diagnosis is because it's all treated the same way. Active, exercise-based approach. Only if there's a red flag, and we'll review what those are, then you should be sending that patient back on an emergent basis to their treating physician, okay? In Canada, I would send that patient to the emergency department or to their family doctor for an urgent MRI. If they have quada equina, I would send them to the emergency department in an ambulance. If there's no red flags, there's nothing that I can do to hurt that patient. The diagnosis is irrelevant. You treat the impairments, you treat the disability, you will get a positive outcome in pain and function and quality of life. Okay, so how do we assess? What do we do? We have to take a history. I've been to a few OPDs. I've been to private clinics in Karachi. I've been to OPDs in Karachi, Lahore, Islamabad. I've been to clinics in northern areas, private clinics in Islamabad, Lahore, Karachi. And this is what I've seen, okay? A patient comes in, I have low back pain. The physiotherapist talks to the patient for 5 minutes. 5 minutes, not enough for a history, okay? And they take the patient, they make the patient lie down in prone, and they put heat and TENS. That's the worst thing you can do. You have to take a proper history. If you take a proper history, minimum 20 to 25 minutes for a proper history. At least if you're an experienced physiotherapist, you can do a proper history in 15 minutes, 20 minutes. minimum. If you're a student and a new therapist, you need at least 20 to 25 minutes to do a proper history. Okay? And history includes the history of their current episode. Okay? Intensity of the pain, aggravating factors, relieving factors, the nature of the pain, sharp, dull, electric, burning, stabbing. This is all important. I also ask my patients to do a disability questionnaire. Oswestry low back index, for example, because I want to know, by decreasing their pain, increasing their range of motion, increasing their strength, am I impacting their functional ability? Am I impacting their disability? Am I impacting their quality of life? You can't tell unless you do a disability questionnaire. Okay, so I also do a disability questionnaire with my patients. And then history also includes past medical history. Okay, do you have any NCDs? Have you had any investigations done? What type of medications are you taking? What is your job? What do you do for a living? What are you having difficulty with at work? If you're a housewife, what can you not do at home? Because ultimately, the reason why that patient is there to see you is because of their low back pain. They can't do their cooking, their cleaning, or their work, right? You have to ask about that. How do you know if you've helped them if you don't ask them what they can and can't do with their activities of daily living or their work tasks? So history should take 15 to 25 minutes, depending on the experience of the physiotherapist. Okay? If you do a good history, you should already know what the problem is. Your physical exam will simply confirm your clinical impression. Okay? The most important part of a physical examination for any patient with low back pain is exclusion of red flags. I want you to ask yourselves, what are red flags? How many of you know what red flags are? You should all know what red flags are. We'll review them in a moment. Okay? Then, once you've excluded red flags, you must test dermatomes, myotomes, reflexes. Okay? And you must know how to test those correctly. Okay? If you get feedback that if Dr. Munif, if people give you feedback that they don't know how to do dermatomes, myotomes, and reflexes, I can do a workshop on that. Okay, we can do a half-hour workshop on how to do a proper neurological scan and how to exclude red flags. We can do that in a few weeks if need be. But you have to do a neurological scan to identify or exclude, as is possible, a radicular occurrence. Okay? And then you also have to ask the patient about psychosocial factors, because we know that psychosocial factors play a huge impact on the prevalence of low back pain, but also its outcome. Okay? So you have to ask people about psychosocial factors. Do they have a support system? Are there concurrent mental health issues? Are there stressors, financial or familial stressors in their life that could be impacting their experience of the low back pain? What a person's life is like, what they are surrounded with in their life, whether it be from their family, their children, their spouse, their mother-in-law, their sister, their work, their boss at work, whatever. It will impact how that person, how your patient perceives their low back pain. Okay? And you cannot do a good job without attempting to address those psychosocial factors. Okay? All right. So if somebody has low back pain with sciatica, okay, again, you must take a history. You must exclude red flags. You must do a neurological scan, SLR, alternate SLR, dural tension testing, dermatose, myotose, reflexes to exclude radicular symptomology or to confirm it. If you suspect serious pathology, i.e., if there are red flags, only then should you really recommend imaging, okay? And you should also think about differential diagnosis with sciatica, metastatic spinal cord compression, spinal injury, spondyloarthritis, etc. All right? When somebody walks in with sciatica, you need to do an extra thorough history and an extra thorough neurological scan. All right? What are red flags? So I like to, I've divided my red flags into the ones that I can assess for, that I actually examine during the physical exam, and then the ones that I actually ask my patient during the history. So is there any active malignancy, but is there history of malignancy? Why is history important? Because cancer can reoccur. Just because they had cancer 3 years ago doesn't mean that it hasn't come back. So you need to know not only if there's active malignancy, but you need to know if there's a history, because there could be reoccurrence and the patient may not know. Okay, so you have to ask about malignancy. You also have to ask about unexplained weight loss or unexplained loss of appetite. That means something serious is going on in the body. People don't just lose weight. That's not normal. Okay? Unexpected weight loss is not normal. Unplanned loss of appetite is not normal. Something bad is happening if your patients report unexplained weight loss or loss of appetite. Okay? What about recent fever and chills or infection? What about immunosuppression? What about pain at rest or pain during the night? Trauma. Hey, if they fell and landed on their tailbone, it's unlikely, but they could have a compression fracture. What if they were in a motor vehicle accident and they had their seatbelt on, okay? They had a seatbelt on here, okay? Lap belts, and they were hit from behind, which means that they were jerked violently forward and their pelvis was pushed back. If there's a seatbelt here and your torso comes forward and you're pushed back, you're essentially compressing your spine. You could have a spinal compression fracture in the thoracic region and not know. Okay? You have to ask them if they've been in any traumatic event. Trauma doesn't just mean a car accident. It could mean a fall. It could mean something falling on them or them falling downstairs. I've seen compression fractures when somebody falls downstairs because they hit their back on the stairs. It's possible. And then most importantly, recent onset of bowel and bladder dysfunction. Now, do we really know what that means? What's bowel and bladder dysfunction? Okay, what does that mean? What that means is you lose bowel control. You poop in your pants. And bladder dysfunction means you cannot empty your bladder. Okay? These are red flags that you must ask any low back patient when they come into your office, your clinic, your OPD. Okay? Now, during the physical exam, this is what I test for. I test for progressive neurological deficiency in the lower extremity. How? Myotomes. Okay? You guys remember what myotomes are. You remember that you have to repeatedly test myotomes because fatigue happens over time. Okay? So, one of the things I love to do the most is I get my patients to walk on their toes and walk on their heels 5 or 6 times, back and forth, back and forth, back and forth, L5S1, right? I look for differences in muscle definition and I look for fatigue. Is one heel dropping down compared to the other? Okay. Are they able to maintain dorsiflexion comparably between one side and the other during heel walking, or are they having difficulty maintaining dorsiflexion on one side compared to the other? Those would be signs of progressive neurologic deficit. Myotomal testing is a repeated process because myotomal fatigue takes time to develop. Doing one repetition will not give you myotomal fatigue. You must do 5 or 6 repetitions, right? You remember that from your training. Okay. Saddle anesthesia. You have to test this. Anal sphincter weakness. You have to test this. And of course, fever. Okay. If I suspect fever, I have a thermometer and I measure my patient's temperature. All right. So these are the red flags that you need to test for. You can do some of them through the history taking, and the others you can do during your physical examination. All right. If you have red flags, stop. Okay. Physiotherapy, no role for physiotherapy here. You counsel the patient, you tell them to remain calm, and you send them to the emergency department because that's when an MRI is needed. If somebody cannot empty their bladder, if somebody cannot feel around the groin area, if somebody has pure myotomal weakness of the hip flexors or the knee extensors, you need to send them to the hospital because there's something serious going on. Especially if your history suggests that they may have a history of cancer, they may have had recent trauma, maybe they're immunosuppressed, something is going on and it's beyond your scope of practice. You're not a physician, okay? You need to send them to a physician for in-depth assessment, all right? All right, let's assume that there are no red flags. That's when you and I as physiotherapists can do our amazing work, okay? Now, what does the evidence tell us? What does the research tell us that works? Number 1, self-management. You have to, so 3 things work. Educating your patient, teaching your patient, empowering your patient, counseling your patient, guiding your patient on how to manage their back pain. That doesn't mean they won't come back to you. Guaranteed they'll come back to you even more. Why? Because they will trust you even more. Why? Because you are truly helping them. You are sharing your knowledge with them. They will respect you. You will not lose business if you have a private clinic. You will gain business. You will gain more referrals because your patients will get better. If you follow this approach, your patients will get better, guaranteed. Okay, so 3 things work. Teaching the patient how to manage their back pain, okay, by giving them education about the condition. When I talk to my patients, I show them my anatomy model of the spine. I explain to them, this is the spinal cord, these are the vertebral bodies, these are the discs, these are the facet joints, these are the nerve roots. I explain the anatomy to them. I tell them there's muscles in 3 different layers, there's ligaments, you know. We can't do much about the ligaments. We can't do much about the bone. What we can do a lot about are the muscles. We're going to work on your muscles. And if we can make your muscles stronger, dynamically stronger, it's going to make your entire back area safe. Okay, so I actually take an anatomy book and I show them pictures of what's happening in their spine. I'll take a model of the spine. I show them the different levels and I explain to them what the treatment's going to be. Then exercise is the second thing that works. Okay, it can be a combination of approaches. You can use biomechanical, okay, which is straight up exercise, strengthening, squats, lunges, bridging, core stability, kettlebell, TheraBand exercises, pulleys into rotation. You can use aerobic, walking to activate the multifidi, balance exercises to get the core firing. You can use mind-body, yoga, Tai Chi, where you're combining static and dynamic stabilization exercises with balance, or a combination. I like to use a combination. Why? The patient doesn't get bored. I don't get bored. It's more fun. The only time that spinal manipulation or mobilization is effective is if it's used in combination with exercise. If you do manual therapy on your own without any exercise or education, you might get temporary relief, but you will never get long-term relief. Okay? You are not practicing in an evidence-based manner. Putting kinesio tape, I'm sorry if I upset people. That's the evidence. Putting kinesio tape on a patient's spine, no benefit. It may feel good up here. They may think that it's helping. There's no evidence. Putting heat and TENS on a patient's back, they'll feel good for a half hour, maybe an hour. You're not strengthening any muscles with that. You're not activating transverse abdominis. You're not activating gluteus medius or maximus by putting TENS on a heat pack or IFC on someone. Doesn't do anything. Acupuncture, waste of time. Okay? So if you're going to use manipulation or mobilization, if you're going to use glides, lateral glides, PAs on the facet joints angled medially to facilitate side flexion, whatever. If you're going to use PAs angled, cranially to improve lumbar flexion, or PAs angled caudally to improve lumbar extension, hey, that's your right. You're wasting your time unless you combine that with exercise and CBT, cognitive behavioral therapy. For individuals with low back pain that's chronic, more than 3 months, the best outcomes occur with exercise and CBT. CBT teaches a patient how to reframe their pain experience. You teach the patient how to think about what they can do, not what they're unable to do. You teach them how to do an activity by pacing, by modifying the way they can do that activity without aggravating their back. It's changing the patient's perception of how they view their pain. Okay? So manual therapy is only effective if you use it in combination with exercise, with or without CBT. Otherwise, passive therapies are a waste of time. You're wasting your time, you're wasting the patient's time. I'm sorry, but that's what the evidence tells us. Okay. This is what I don't use. Okay. If you come to AKUH, okay, if you come to AKUH OPD and you watch me treating a patient with chronic low back pain, you know what they'll be doing? They'll be doing exercise. They'll be doing balance board. They'll be doing treadmill. They'll be doing recumbent bike. They'll be doing squats. They'll be doing lunges. They'll be doing TheraBall. They'll be doing medicine ball exercises. They will not get acupuncture. They will not get ultrasound. They will not get PENS or TENS or IFC or orthotics or lumbar belts or lumbar corsets or insoles or traction. They will not get any of that. Why? There's no evidence. Not a single expert in the last 5 years in 6 major international guidelines has said that these interventions work. Okay? This might be shocking to some of you, but it's the evidence, and I'm sharing the evidence with you. Whether you choose to follow this or not, I recommend that you read the evidence, you read the literature, and convince yourself. Use this as a guide, but you need to convince yourself. Read the guidelines that I've shared with you, and you will convince yourself that exercise, education are the 2 best ways to treat low back pain. All right. Okay. So here are my tips. Okay. Somebody walks in with acute low back pain. So for example, they got out of their car 1 day ago and all of a sudden they had low back pain. Okay? They got out of their car, and all of a sudden they got low back pain. Nothing else happened. Okay? What do? I take a history for 10 to 15 minutes. During that history, I exclude some red flags. Okay? After I've done a thorough history, I do a physical examination. The first thing I do is exclude the other red flags. Then I exclude radiculopathy by doing dermatomes, myotomes, reflexes, SLR, etc. Okay? Once I know that there's no red flags, I'm going to reassure my patient. It's okay. I know you have pain. It's not pathological. Reassure them. Tell them that they will have a favorable prognosis. If you tell somebody, oh, ye masla hai, ye condition bahut masla hai, aapka dard bahut masla hai, I don't know if you'll get better. Psychologically, are they going to get better? No. You have made your job 10 times harder. But if you reassure your patient, I know you have back pain, but the good news is red flags nahi hai. This is mild condition that will respond well to physiotherapy. Okay? Tell them, advise them that they should remain as active as possible. No bed rest. Bed rest is contraindicated for low back pain. I know so many physiotherapists and doctors that tell their patients, don't do anything for 1 week. What happens when we lie down for 2 days? What happens to our muscles? Atrophy. Is that good or bad for low back pain? Bad. It's going to make it worse, right?
Yes.
Bed rest is contraindicated. No, no, no. Advise your patients to remain as active as possible. If they can't walk for 20 minutes, okay, walk for 5, walk for 10. If they can't do cooking for 2 hours, okay, do cooking for 20 minutes, then take a break, then do 20 more minutes, then take a break, then do 20 more minutes. They have to remain as active as possible, no bed rest. Okay? It's okay to use non-steroidal anti-inflammatories and weak opioids for short periods of time. If it's a severe acute case, this is a day earner, he has to go to work, fine. Let him take some medication, but only for a few days, okay? Until the acute episodes settle down and you can become more effective in treating the actual cause of the condition. If you think there's radiculopathy or something more sinister going on, like compression fracture or significant spinal stenosis or cancer, something else going on, or if there's no improvement with physio in 4 weeks, ethically and morally, you need to send that patient to a doctor. Because what you're doing is not working. Somebody else has to help them now. Fair, right? Okay. What happens if we have somebody with chronic low back pain? It's okay for them to use non-steroidal anti-inflammatories and antidepressants. Why antidepressants? Tell me why they might need antidepressants. Why will they need antidepressants? They'll need antidepressants because they've had chronic low back pain, months and years. They're depressed. They're anxious. They're frustrated. They're not happy. They have psychosocial factors contributing to their perception of what they are able to or not able to do. They have psychosocial factors contributing to their perception of their pain. They need antidepressants. So if you have somebody who comes in who looks flat affect, like this, when you try to joke with them, there's no laughter. They don't react. They keep poker face. Okay? If they seem down, if they seem depressed, and they're not on antidepressants, they're not seeing a psychologist or a psychiatrist or counseling, you should After you've assessed them, also refer them to a mental health assessor. Your treatment will not be effective if you do not have somebody help you address their psychosocial factors for chronic pain. In Pakistan, that's very poor. Okay? I'm sorry, but most physiotherapists don't think about that. Some do, but most don't. Some do. And for those of you who do, awesome. I'm happy for you. I'm proud of you. You are ambassadors of our profession. You are practicing in an evidence-based manner. But for those of you who have patients with chronic pain, any kind of chronic pain, but specifically low back pain, and you ignore the psychology, you ignore their depression, you ignore their psychosocial factors, you will never succeed in effectively treating their pain effectively in the long term. You will fail. And the patient will have a bad experience with you and with physiotherapy. In chronic low back pain, you must address psychology. You must. You're not qualified to do it. I'm not qualified to do it. But you can send them to a counselor who is qualified to do it. Okay? So they can use NSAIDs and antidepressants, no problem. Exercise therapy is the most effective. All right? Get them walking. My chronic pain patients, they don't get to lie down. There's no lying down. The only time they lie down on the bed is when I teach them bridging and active straight leg raise exercises and sideline for glute med, clamshell. Otherwise, they're on the treadmill. They're on the biodex doing balance. They're in the parallel bars doing high marching and lateral walking. They're on the stability ball doing arm and leg lifts. They don't get to lie down in my OPD. Okay? None of that. Psychosocial interventions. You have to teach the patient to change their outlook on their pain. They have to focus on what they can do, not what they cannot do. So I tell my patient, the next time you come see me in 1 week or in 4 days, I want a list of 5 things that you can do. They come back. I can walk for 7 minutes. I can wash 3 dishes at a time. I can stand for 2 minutes. I can put my t-shirt on myself. I can get out of bed myself. Then I tell them, okay, write down 5 more things that you want to be able to do in the next 1 to 2 weeks. So goal setting, okay? I don't set the goals for them. I ask them, what do you want to do? What do you want to be able to do? And then the exercises I give them are catered to simulate those goals. So if somebody says to me, I need to be able to give my 2-year-old a bath. Now, to give a 2-year-old a bath, what do you have to do? You have to bend, right? You have to be able to bend. You have to be able to kneel, right? You have to be able to kneel. You have to be able to squat, crouch, reach. So the exercises I give them will be kneeling. So I would have them, for example, I don't know if you can see this. I'm kneeling, okay? I'm kneeling. Okay, so they're in kneeling position with pulleys, and I get them doing rotation with the pulley while they're kneeling, okay? Or the other way. Or retraction, reaching and back, but they're in kneeling, or double kneeling, or, okay, I have them do deadlift. So weight is here. They do deadlift. This is the safest back exercise, believe it or not, okay? Or crouching. They're in crouching, and they can do pulleys out to the side. They can do rotation pulleys. They can do up pulleys. They can do pulley downwards. But I pick exercises that replicate or simulate the day-to-day or work activities that they have told me they need to be able to do, to be a mom, to be a housewife, to be a day laborer, to be a doctor, to be a nurse, to be a secretary, whatever. Use that information to identify the exercises that will help them achieve their goals. Okay? Again, if you think based on your history and your physical examination that there are red flags and their past medical history is worrisome to you, they're postmenopausal, they've had trauma, then you need to refer them to a medical specialist. It could be their family doctor or it could be the emergency department. I prefer to refer patients back to their family doctor. Why? Because their family doctor has their most complete history. Okay? And I actually will call the family doctor and say, hey, I think there's something serious going on with Mr. So-and-so because I found A, B, C, D, E. I think we need an MRI. What do you think? The advantage is now you have a relationship with the family doctor as well. Okay? And they know that you care about patients. They will send you their patients. Okay? So the advantage here, if you own a clinic by yourself, even if you're an OPD, doctors will respect that you make that extra effort and you will get more referrals. Okay? So, but it's good clinical practice. The bonus is you're going to get more referrals, right? That's a good thing. Okay. So again, chronic low back pain, NSAIDs is okay. You must address their psychological status, exercise therapy from day one, address psychosocial interventions, and if your red flags fail, if you think that there are red flags there, contact the family doctor and arrange for assistance with MRI or ask the family doctor to arrange a specialist consultation. All right? Okay. Now, remember I told you that the only time, based on experts, not me, based on 6 guidelines in the past 5 years from world-renowned experts on low back pain, the only time that manual therapy is effective is if it's used in combination with exercise, with or without CBT, okay? And there's only certain types of manual therapy that are effective, specifically thrust and non-thrust mobilization. So mobilization PAs or glides or manipulation adjustments, okay? I personally am not a proponent of manipulation. Why? It's not a normal movement. It's an abnormal movement. I don't want to replicate an abnormal movement in a potentially inflamed or affected joint. I don't see the anatomical advantage of that. Mobilization, maybe, depending on the situation, especially mobilization with movement. Mobilization combined with exercise, yes. Even more importantly, teaching a patient how to self-mobilize. I'm going to give you an example, okay? Somebody has frozen shoulder. They have capsular tightness, okay? We want to stretch the capsule, okay? So we can do an inferior glide. We can do traction distraction, inferior glide. But patient can't do that at home, right? What can they do at home? What I tell them is put your hands on a table and lean forward. That's mobilization, self-mobilization with movement. Very effective, okay? And as they increase in range, they can put their arm against the wall, and as you move closer to the wall, you're getting inferior glide. It's going down, and then eventually anterior, right? Down and forward. Self-mobilization is very important. Anyways, so if you have 4, okay, so what this research is telling us is the best time to use manual therapy is if these conditions are met. These conditions are met. The probability of success with manual therapy increases from 45% to 95% if it's an acute case. The duration of symptoms is less than 16 days. If there are no symptoms below the knee, okay? If there's no lumbar hypomobility, okay? If at least one hip has greater than 35 degrees of internal rotation, And if fear avoidance beliefs questionnaire score is less than 19. If you have 4 out of 5 of these factors, then if you use manual therapy, it might actually help your patient. Otherwise, it's a complete waste of time. Evidence-based, okay? Now, what about exercise? Trunk coordination exercises, strengthening exercises, bridging, transverse abdominis activation, glute med activation, ball exercise, stability ball exercises, rotation with pulleys or TheraBand, chest press, leg press, all different exercises, endurance exercises, elliptical, rowing machine, walking, running, treadmill, recumbent bike. Okay, so there are certain patients that respond very well to an exercise-based approach. Generally, if the patient is below 40, okay, if the prone instability test is positive, okay, then there's a need for stabilization exercises. You need to do them, right? If there's aberrant movements with motion testing, i.e. a degree of hypermobility, hyperflexibility, but aberrant movements, we need to tighten things up. Strengthening is a good indicator, is a good treatment option. And if the straight leg raise is greater than 91 degrees, okay? So there's adequate hip mobility to do functional strengthening. You can do squats, you can do deadlifts, you can do lunges, etc. What about centralization and directional preference exercises? Now I'm talking about McKenzie protocols. Some of you may be familiar with McKenzie protocols, hopefully. So there are times when repeated movements, repeated exercises, or procedures to promote centralization in the symptoms with patients with acute low back pain and referred leg pain may be useful. So you want to utilize repeated exercises in a specific direction. So for example, there's a very strict protocol that the McKenzie method follows, right? You test repeated, depending on the symptoms. I'll test the patient in standing first because they're already in standing. And if I can get centralization in standing, hey, I'm going to do that because it's functional, right? It's functional. Why not? And it also allows me to see if there's a list. So, I would test, for example, repeated flexion in standing. Does it refer in a peripheralization of symptoms, i.e., does a low back pain move from a central location to further down the leg, to a more peripheral location? That's bad. We don't want that. We don't want peripheralization. We want centralization. 9 out of 10 times, McKenzie says, we're dealing with a posterolateral disc protrusion. Again, I don't care about anatomy in this case. I'm responding to signs and symptoms. But McKenzie protocol says 9 out of 10 times, when somebody comes with low back pain with sciatica, it's a posterolateral disc protrusion. That means that the disc is bulging out and either to the left or the right, hitting on a nerve root, and that's causing the referred pain, okay? And the idea is that by doing repeated extension, we're decompressing the compression on that nerve root. So you want to look for a direction of movement that results in centralization of the symptoms, even if the centralized symptoms are more painful. Example, I come to your OPD. I say Dr. Sohel or Dr. Saresh or Dr. Kanwell. I'm looking at our participants here. Or Dr. Mir Murtaza. I have low back pain, and the low back pain is going down into my right buttock. Where's my buttock? Here. and it's going down the posterolateral aspect of my leg to the middle of my right calf. It's a 10 out of 10, Dr. Murtaza. 10 out of 10. It's really, really bad. Dr. Murtaza came to Habiba's lecture. Dr. Murtaza reads many, many research articles, and he or she knows that evidence-based practice is needed. There's no red flags. And now they're going to try to centralize the patient's pain. So Dr. Murtaza says to me, Habiba, I want you to bend forward 10 times and tell me if that changes the location of your pain. And Habiba says, it makes it go down into my ankle. Oh, okay, stop. Now, Habiba, I want you to bend back into extension. Let's do repeated extension, okay? Repeated extension is not this. We're not moving our hips. We're moving our low back. That's repeated extension, not this. This is not hip extension, low back extension. When you thrust your hips forward, you're not isolating the movement to the low back, okay? This is lumbar extension, not that. I hope you see the difference. So Habiba does repeated extension in standing, and wow, the pain goes from the ankle to the buttock, but it's more intense here. It feels like a 12 out of 10. That's okay. Centralization of symptom location is a priority, even if symptom intensity is a little bit greater. I'm not going to explain why. It's too complicated. For those of you who want to know why, go to PubMed, type in McKenzie Protocol, and you'll get a lot of papers, and they'll explain to you the biomechanics, the arthrokinematics behind why that happens. Okay, so it's okay to use centralization and directional preference exercises if you can isolate a directional movement that results in a centralization of symptoms, okay? And you can use this with acute, subacute, or chronic low back pain patients who have deficits in mobility, okay? So if there's limitation in flexion or side flexion or rotation or extension, all right? Okay, what's next? Okay, now, how many times have we been told flexion is bad for the spine, right? It's not. Flexion is not bad for the spine. Says who? Who says flexion is bad for the spine? Flexion is bending. We have to do this all the time in day-to-day life, okay? We have to do this functional movement all the time in day-to-day life, okay? And what we need to do is reintroduce it gradually into our patient's rehab protocol. It's very, very useful in combination with manual therapy. So if somebody has a flexion deficit, I could do PAs angled cranially on the spinous processes in combination with lumbar flexion exercises in sitting or in standing, and then eventually adding strengthening exercises. So keeping the back straight, and doing lifts. Okay, my back is straight, right? Okay, that strengthens the back in flexion. And it's very actually effective. And you must do progressive walking. You got to combine all that with progressive walking. Really, 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 really important. And nerve mobilization techniques. I'm going to show you one for the sciatic nerve a little bit later on, little trick I learned. It's really, this group of treatments is very effective when you have older patients with chronic low back pain and radiating pain. You know, I do a joint clinic with Dr. Gohar Afshah, who's the head of anesthesiology at AKUH every Friday. And I see about 5 or 6 patients. These are all people over, majority, 90% are over 50, over 60, over 70. They've had chronic low back pain. I'm talking 2, 3, 4, 5 years. They've had epidurals, injections. They're on major medication. Okay, what do I do? Treadmill, balance exercises, flexion exercises, bridging. Okay, that's really, really important. Very active approach. So flexion exercises are not the enemy. They are actually good to do, especially in older patients with chronic low back pain and radiating pain. Why? Think of the prevalence. What structures would normally be affected, right? Central structures. So we want to gap the spine. So flexion is very useful. We're almost done. Just a few more slides to go. Okay. What about nerve mobilization procedures? So lower quarter nerve mobilization procedures are very effective in reducing pain and disability in patients with subacute and chronic low back pain and radiating pain. I'm going to try to show you one for the sciatic nerve. I hope I can do this and that you can see. Let's see how I can manage this. Okay, so what you want to do, let's see here. Bear with me. Okay, so you want to, so let's say the reason why you want to do nerve mobilization is we have a nerve. There's a sheath or an envelope around that nerve. Okay, we want that nerve to move freely within that envelope. We don't want it to be stuck because of scar tissue and inflammation. That can cause pain. We want that nerve to be able to glide nicely within that envelope or that sheath. So nerve flossing or nerve mobilization procedures allow for the nerve to become untethered from surrounding envelopes. Okay, it's a great way to improve flexibility and to decrease pain. So for sciatica, for example, what I would do, okay, I would tell the patient, okay, hands behind your back, slump, okay? Then you want to tell the patient to straighten the knee until they feel their pain. Oh, right there, okay? So the patient can feel the pain, okay? So they're going to straighten their knee. That's where they feel the pain. Then what we're going to do is we're going to add in a distal movement. The distal movement is dorsiflexion, okay? Dorsiflexion increases the tension on the nerve, as does cervical extension. So what you're going to do is you're going to tell the patient, slump. That increases the tension on the nerve. Then they extend their knee until they feel tension in the back of the knee. Okay, then they're going to dorsiflex their ankle and extend their neck. And then down, plantar flexion and cervical flexion. Dorsiflexion, cervical extension. Cervical flexion, plantar flexion. Small amplitude movements. What you're doing is you're flossing the nerve. You're mobilizing the nerve along its length to untether it. Okay? This is a really effective technique that you can use with your patients. Lower extremity, lower quadrant nerve mobilization procedures are very effective in reducing pain and disability in patients with subacute and chronic low back pain and radiating pain. This is the same principle as if somebody had carpal tunnel syndrome. Okay, they have carpal tunnel syndrome. Okay, problem is here, right? You do upper limb tension test, reproduces the symptoms here. We want to mobilize the nerve. We want to loosen it up in this area. I would put them in the position, okay, where the median nerve is being stretched, okay, and then I would add neck flexion, depression, neck flexion away. Depression, neck flexion away. What is that doing? That's mobilizing my median nerve. We're doing the same thing with the sciatic nerve. You can use this process for any nerve in the body. Very effective. Okay, I'm getting sidetracked. Let me go back. All right, now I keep talking about patient education and counseling. Okay, I want to spend a little bit more time talking about behavioral education. Remember, I kept telling you, advising you, you must address psychosocial factors, right? Psychosocial factors are Really important to address. Okay, how do we do that? We do that by cognitive behavioral therapy. As physiotherapists, we can't do that completely. We need the help of a psychologist or a counselor, but there are some things that we can do that are a part of CBT. Okay, and I've given you some examples here. Okay, so for example, activity pacing. Instead of doing all the housework in 3 hours flat, you counsel your patient to do 1 hour every day. Instead of doing 3 hours in one day, they do 1 hour on Monday, 1 hour on Tuesday, 1 hour on Wednesday. Activity pacing. Okay? Next one is attention diversion. Okay? We know that if you have a headache and you distract yourself, you don't feel the headache as badly, right? Okay. So if somebody has chronic pain, you know what I tell them to do? Put on your favorite music. Not your favorite TV show. Because that means they have to sit and be sedentary. I don't want them to sit and be sedentary. I want them to be active. Read a book. Okay? Put on some music. Do some art. Do some arts and crafts. Okay? Do an activity to distract yourself from the pain. Okay? Attention diversion. Call a family member, call a friend on the phone or on FaceTime and talk to them. Okay? Cognitive restructuring. What does that mean? That is your outlook on life. Instead of saying, I used to walk a half hour, I can't walk a half hour anymore. We teach our patient to say, you know what? I now can walk 10 minutes. Instead of saying, I can't walk a half hour, you teach them, you train them to think, I can walk 10 minutes. You're restructuring how they view what they are able to do or unable to do. Goal setting. This is extremely important. Okay? You must ask your patient to pick 5 or 4 things that they want to be able to do in 2 or 3 weeks. And that way, both of you can work towards those goals as a team. Okay? Those goals can be anything. It can be, I want to be able to put on my shoes myself. I want to be able to reach at the top of the kitchen to get my teapot. I want to be able to kick the football with my son for 10 minutes. It could be any goal. Then what you do is you modify the exercises to mimic or simulate those goals or those activities to help your patient achieve those goals. Graded exposure, what does that mean? That means that they don't have to walk a half hour on the treadmill at the first visit. Just walk 5 minutes on the treadmill at the first visit. On the second visit, walk 7 minutes. On the third visit, walk 8.5 minutes. You increase activity level gradually, but on the first day you start, set the standard. If you take the time to explain to them why exercise is important, they will listen to you, they will comply, and they will come back because they will feel better. Motivational enhancement therapy. Okay? How do we do that? Remember I told you we goal set. You show them, look, 2 weeks ago, you told me that one of your goals was to walk 15 minutes. Yar, today you walked 20. Not only did you meet your goal, you exceeded your goal. This is how you motivate them. You show them the things that they've accomplished, what they're able to do, what they've been able to do, how much they've improved. Yar, instead of doing 30 reps, you're now doing 60. That's amazing. Give them lots of positive feedback. Maintenance strategies. It's important for us to realize that we might not be able to make our patients 100% pain-free. That's okay. If somebody has had chronic pain for 10 years or 2 years or 5 years, do you think they're ever going to be pain-free? Probably not. But they're going to get a lot better if we do our job properly and motivate them, right? So once they're 80% better and they hit a plateau and you don't think they can benefit anymore, you need to make sure that you've given them the knowledge to be able to maintain their gains, that they don't go backwards. Okay? So make sure you have an exercise program that they can follow on their own, okay, to maintain the gains they've made. Problem-solving strategies. For example, we need to teach them how to do things differently, okay? So if somebody needs to lift a suitcase and it weighs 30 kg, it's better if they actually make 2 suitcases, each 15 kg. That's safer. So teaching them how to problem solve different activities to make it easier for them. This is what I mean by CBT, by patient education and patient counseling. Yes, it takes time. You can't do this in 5 minutes. This takes 10, 15 minutes. But you do this while you are giving them the treatment, while they are on the treadmill walking, while they're on the recumbent bike cycling, while they're on the biodex doing balance exercises, while they're doing squats or lunges. You're giving them this motivation and these tips and this feedback. Okay. Now, a few more tips. It's important for the patient to understand the anatomy so that they understand what you're trying to do. So take the time to teach them a bit about the spine. These are the muscles, these are the vertebrae, these are the discs. Use pictures or use a spinal model, okay? And explain to them that most people get better from low back pain. Okay, and they really need to try to keep as active as possible. No bed rest. They have to try to maintain their activity levels as much as possible in a gradual manner. Lots of positive feedback. Okay, what type of exercise? It must be for patients with chronic low back pain without generalized pain. So just chronic low back pain. You need to prescribe moderate to high intensity exercise, okay? For patients with chronic pain and generalized pain like fibromyalgia, or they have low back pain, but they also have upper back pain, neck pain, headaches, shoulder pain, okay? It must be a bit more gentle, okay? Your exercise approach has to be a bit more gentle. So you start with low intensity and you build up gradually, okay? More endurance exercises versus ballistic power type exercises. It's a bit more progressive. Okay, now, how do we know that we're making a difference? I'm gonna be honest with you. One of the weakest areas in physiotherapy in Pakistan is outcome measures. Most people that I've seen in OPDs, different OPDs in different cities and different private clinics don't use these kinds of outcome measures. They use pain scale. Who cares? Who cares? What does it mean when a patient's pain goes from 4 to 8 or 8 to 2? That doesn't tell me if they're happier. It doesn't tell me if they're sleeping better. It doesn't tell me if they feel stronger. It doesn't tell me if they can walk longer. It doesn't tell me if they can work longer. It tells me nothing. It's completely useless. Who cares? This is what we need to look at. Is as their pain decreases, as their muscle strength and endurance improves, does their function improve? The only way to tell that is by doing these outcome measures, okay? To begin with, you can use numerical rating scale, fine. If you're not used to doing any outcome measures, start with numerical rating scale and range of motion, at least do some objective outcome measures. But then you should add, you've got lots of options, and these take 2 minutes. If you help your patient do these questionnaires, 2 to 3 minutes is all it takes. It's not time consuming at all, okay? Oswestry Disability Index, Roland Morris Disability Questionnaire. These two are my favorite. because they're quick. Actually, this one is my favorite. It's really fast. 2 minutes and it's done. And I get the patient to do that the first visit, and then at week 3, week 6, week 9, if they're still with me. Most of my low back patients are discharged after 4 or 5 visits. They're 80-90% better, if not 100% better. So usually at baseline, first assessment, I do it, and then at week 3. By then it's been 6 visits, and I discharge them. They're done. They're fine. So I like to use this one, but using outcome measures, because then you can show the patient, look, on day 1, this was your score. On day 14, you've improved by 80%. You see, you're proving to them that they're getting better. You're changing their perception, okay? Because how many times has range of motion improved? Has reps have increased? Duration has increased in exercise, but the patient says my pain is no better. Does that make sense? It doesn't make sense, right? You have to prove to them that they're getting better. This is a good way to do it, by doing outcome measures. This is an example of the Roland Morris Disability Questionnaire. Okay, so basically, for every single task that is true, they check mark, and the more check marks they have, the worse is the effect of their low back pain on their life. So on baseline, they may have 18 check marks. They can't do 18 of these things. Or if they do 18 of these things, they get low back pain. After 4 sessions, maybe it's only 10. That means they've improved by almost 50%. That's amazing. You can show them that improvement. That's it. That's all I have. Any questions? I think you can maybe put them in the comments or the chat if there's any questions. I'll do my best to answer them. Thank you, Sadia and Amaraj. Thank you, Azam and Alion. Thank you, everybody, for joining. I'm just saying thank you to the people who've enjoyed the presentation, but I want to thank everybody for attending.
Yes. Very informative session.
Good, good. Do you have any questions?
Yes. Anybody have any question regarding low back pain?
Hello.
Because I have some, I guess.
Yes.
Okay. So, hello everyone. I am Mariam Arif. I am the General Secretary of United Health Organization and currently an MBBS student in my 3rd year. First of all, thank you so much for this session. In the beginning, we did have some, I guess, technical glitch. It was, I believe, because of which a lot of viewers could not view the live session. But then it was restored, and we did have an influx of messages and feedback that I can still see coming. So I do not have words to describe how amazing this session was and how informed, productive this was. I mean, this 1 hour or 1 hour 24 minutes that I've spent in this session couldn't get more productive. It was very precise. It was very to the point. And you covered so much in this session regarding lower back pain and sciatica, because often these medical terminologies and these topics that are related to medical science are complex. It's really difficult to explain all of these terms, but you took a very systematic approach. You took a step-by-step approach, and you did not just tell us about things that we practice here, but things that are done at an international level. You pointed out things that are wrong, and you pointed out that how we can improve whatever we are doing through research, and how research is also very, very important. So I must say that thank you for all the time that you put into this, the effort, the energy, and your hats
My
off to your
pleasure.
dedication as a physiotherapist. You truly are an inspiration for all those young physiotherapists that I'm sure they must be looking up to you to become future physicians and consultants like you. Thank you so much. I got a lot of stuff to learn. I can't just summarize it in a few minutes about how history is very important, something that is neglected,
Cool.
and
You know,
intensive
I'm really
history is very
fortunate.
important. We
Yeah.
just how we just do not have to just jump into diagnosis and go to imaging and all of those. We need to have an extensive history so that we can get to know the patient through the history alone. And how you, I must say that it was very interesting to see you demonstrate all of those exercises as well. I mean, this is like you doing your best. Although we have this online medium, we are not physically present, but you did your best, and you did not let that one thing miss out. You showed us physically, you demonstrated to us that how we can really do those exercises as well. And interestingly, you also covered the psychological aspect itself, and how important it is to bring the anatomy to the patient itself, themselves as well, because this is something that we do not see here
Yes.
very often. Doctors do not really like to do that. This is what I have experienced. But you said that it's very important for the doctor to look at the psychological aspect of the patient as well, and to
Yes.
make sure that we counsel the patient and we tell them that what's actually happening with them and what we are going to do with them. So thank you so much, and we hope to have further sessions with you as well in the future. Please do stay connected with us. It was wonderful
Absolutely.
having you, and you are like we do not want you
You
to
know
miss
what would
out
be
on these
really
sessions.
cool?
Please join us in the future
Let's
as
do
well.
let's do a
Uh,
practical session where I can show you some exercises to your audience, some practical tips and exercises that they can prescribe to their low back pain patients. I think that would be really useful for people. So maybe in a few weeks we can work on that as our next session, and I'll make sure that I have an assistant with me so that when I'm demonstrating, you can clearly see what I'm doing, and I'll have some equipment with me as well to be able to demonstrate. Okay. I'll work with Dr. Munif to sort
yes,
that out
yes,
if you're
inshallah, in the
willing
future.
to do a second session.
Definitely.
We can do a practical
Yeah, sure.
hands-on session.
Okay, yes.
And you know,
In the future, inshallah, we look towards improving even more and having all of these components as part of our session as well.
perfect.
Thank you, Mahmir, for moderating the session and for spending
You're
your time
most
with us.
welcome.
And thank you to the officials of the United Health Organization as well. There's a list of names, but thank you everyone collectively and the audience. Please do give us your feedback and do tell us what topics your sessions as well, because this is what keeps us going. The feedback, and this is our fuel. This is what gives us the motivation to have these sessions. Although UHO is a young organization, but I feel that in terms of webinars, and they're doing their best and always trying to do their best to impart their knowledge to the general public and the all the aspiring medical
Yeah.
students and all the
You know,
aspiring physicians and consultants as well.
I'm
So
very
thank you.
impressed with the initiative that I've seen in Pakistan amongst the physiotherapy community, as well as the student medical, nursing, and physiotherapy community, the allied health community, taking initiative to educate the public with various organizations such as United Health Organization. It's really good to see that. So I'm clapping and thanking all of you for your efforts. It's a wonderful thing that you're doing, providing this education and counseling and knowledge to our public, to our citizens, and to colleagues, fellow students. It's wonderful. Keep
Thank
it
you
up.
so much. Thank you so much, and thank you for playing your part in making this a success as well.
Okay. Okay.
So see you all. thank you so much, and see you all in the next session as well. We'll keep doing these sessions, inshallah. So please be there with us in our next session as well. Till then, Allah Hafiz,
Allah Hafiz.
and take care
Allah
and stay
Hafiz.
well.
Allah Hafiz.
Bye, Munir. Dr. Munif. Bye.
Bye.